Hello everyone. Today we will discuss about inguinal hernia. The main concern will be history and examination because that is most important. So the hernia is by definition, you know by now, abnormal protrusion of the whole or a part of viscus through the walls that contain it. Inguinal hernia can be direct or indirect. In indirect, it enters through abdominal cavity to deep ring, to inguinal canal, to superficial ring. Indirect one, abdominal cavity, Hasselbeck's triangle, inguinal canal and superficial ring. It may be complete or incomplete. Complete contents reach till the bottom of the scrotum. In incomplete, the contents do not reach till the bottom of the scrotum. I'll show the diagrams. This is the deep ring, this is the superficial ring, this is the inguinal canal. Now, the hernia coming from abdomen through the deep ring to inguinal canal and exiting into the scrotum through superficial ring is indirect inguinal hernia. Again, the hernia which is entering inguinal canal through the defect in the abdominal wall and again exiting to the scrotum through superficial ring is direct hernia. If the contents are reaching till the bottom of the scrotum, it is complete. If they are not reaching till the bottom, they are incomplete. Now, the content can be either enterocele or omentocele. Enterocele is what? Enterocele is intestine. Omentocele is what? Is omentum. So, when the content is intestine, it is enterocele. When the content is omentocele, it is omentum. History. You know, particulars of the patient are very important. Age. If the patient is young, indirect is more common. If the patient is old, direct one are more common. The risk factors. Smoking is a risk factor. Obesity is a risk factor. Respiratory disease like asthma, TB, bronchitis are the risk factors. Chronic constipation is a risk factor. Straining is a risk factor. The chief complaints are pain. May or may not be present. If present, usually long before the appearance of the lump or a swelling at the time of presentation, omentum or mesentery may be coming through it and stretch over them may be causing pain. The lump, with or without pain, ask how did it started? Cuffing and weight lifting increases the lump or not? Where it first appeared, above or below the groin crease. If it start in the groin and extend into the scrotum, it is inguinal, but some hernias start below the groin and gradually ascend upwards, that is femoral hernia. The size and extent of the swelling is important. Does it appear automatically? Does it disappear automatically on lying down? Signifies the spontaneous reducibility. Direct one mostly disappear automatically. Indirect has to be reduced if it is big. History of present illness is important. Past history is also important. In this, you have to ask any history of surgery because a hernia can be a recurrent hernia or even after appendectomy, division of nerve which is iliohypogastric nerve may lead to weakness of abdominal muscle which are leading to direct hernia. Personal family treatment history is also important. Examination is the most important thing you should do. First examine the patient in standing position, then make the patient supine. Inspection. Swelling size and shape is to be examined. If it is pyriform, mostly indirect. If it is spherical, consider direct. Position and distance are important. Complete, incomplete. You know by now. Femoral is coming from down above. Visible peristalsis, skin over the swelling. Obviously, you have to see. It can be normal. It can be reddened. If it is reddened, strangulation should be suspected. Scar of previous surgery can be seen. Impulse on cuffing is very important finding. Presence of expansile cuff impulse is almost diagnostic of hernia, but more important to know is that absence of cuff does not exclude hernia. The palpation, position and extent are definitely confirmed. Swelling descending into the scrotum or labia majora is inguinal hernia. If confined to groin, differential diagnosis can be femoral hernia. Inguinal hernia is above the inguinal ligament and medial to pubic tubercle, but the femoral hernia is below the inguinal ligament and lateral to the pubic tubercle. There is a test which is called getting above the swelling. How to do it? You have to hold the root of the scrotum between fingers and the thumb. If you are possible to get above the swelling, it is a scrotal swelling. If you are not able to get above swelling, it is inguinal scrotal. What is meant by getting above the swelling? Just assume there is a swelling which is in the scrotum and you are holding it between the thumb and the finger, and at a point you think that swelling is no more there and you are able to just hold content of the spermatic cord or contents of the cord in your finger and the thumb, then it is getting of the swelling. But if the swelling is going throughout the abdomen, you will not be able to approximate your finger and the thumb. So that is for inguinal scrotal swellings. Consistency. A dewy consistency is there for omentum and intestine will have elastic consistency. There are two cardinal signs of uncomplicated hernia. You can be asked in examination, theory or practical or even MCQ. Impulse on cuffing and reducibility are the two cardinal signs. Deep ring occlusion test is also important test which you should do. Patient should be in supine position. Hernia should be reduced and thumb or index finger is placed at the deep ring and the patient is asked to cuff. Cuff impulse present, it is direct hernia. If cuff impulse is absent, it is indirect hernia. Zeeman test is done by 3 fingers, index fingers over the deep ring, middle finger over the superficial ring, ring finger over the femoral ring. So the patient is asked to cuff now. Impulse on index finger shows the indirect hernia, on middle finger shows the direct hernia, and ring finger shows the femoral hernia. Now some questions which are very important. In fat people, how will you reach the pubic tubercle? Is the question. Answer is, in fat people, we reach the pubic tubercle by following a rectum longest muscle. What is the differential diagnosis of the inguinal hernia is the next question. The differential diagnosis is or are femoral hernia, congenital hydrocele, vaginal hydrocele, Lipoma of the cord, undescended testis, superficial inguinal pouch, enlarged inguinal lymph node. Imagination test, you should know theoretically but do not perform unless otherwise asked to do so because it is painful. Cardinal test is one thing which is done in children. And this what we do is hold the child from the back by both the hands on the abdomen, press the abdomen and lift the child up. This will make hernia apparent. Percussion, it can be done, usually not required, but it can be done in standing position. Dull is omentum, intestine. So what is deep ring? Deep ring is U-shaped condensation of the fascia transversalis located 1.25 cm above the mid-inguinal point. Superficial ring is triangular opening in external oblique aponeurosis and is 1 to 1.25 cm above the pubic tubercle. Inguinal canal is what? It is 4 cm oblique passage situated at the medial half of the inguinal ligament. It extends from the superficial to deep ring. The boundaries of inguinal canal are: front is formed by external oblique aponeurosis and congenital laterally. Behind is formed by the fascia transversalis and congenital medially. Above is congenital muscle. Below is inguinal ligament. So next question is, what is conjoint tendon? These are the arches fiber of internal oblique muscle. Next question which comes to mind is mid-inguinal point. It is the midpoint between ASIS and the pubis symphysis. Next question that comes to the mind is, what are the boundaries of facial triangle? Medially, it is formed by the outer border of rectus abdominis. Laterally, it is inferior epigastric vessels. Inferiorly, medial part of inguinal ligament. Floor is formed by the fascia transversalis. Triangle is traversed by the medial umbilical force, that is obliterated umbilical artery. So, what are the types of inguinal hernia? You know, complete or incomplete. Incomplete, Bibonocele, hernial sac, confined to inguinal canal. Funicular, hernial sac goes beyond superficial inguinal ring, reaches up to the upper pole of the testis. What are the swelling that show expansile cuff impulse, meningocele, encephalocele, laryngocele, and empyema necessitans? How will you manage the patient of hernia? Always offer surgical repair after some basic investigation, but your recent Bayesian lab says it can be managed conservatively, but I still consider you should go for a surgery. Yeah, you can ask the patient to consider surgery, but do not say, okay, go home and do nothing. What are the complications of hernia? The next question. Answer is, it can become irreducible, it may become obstructed, it may become strangulated. So irreducible hernia is, it cannot be reduced inside the abdomen due to adhesion of the hernial content, but blood supply is intact. So obstructed hernia is, in addition to irreducibility, there is colicky pain first over the hernia, then in the abdomen. Hernia becomes tense and the tender, if not relieved, cardinal feature obstruction will be there, and these are pain, vomiting, distension abdomen, and constipation. Strangulated hernia is where there is ischemic necrosis of hernial content due to impaired blood supply. Hernia will be irreducible, cuff impulse will not be there, it will be tense, tender, and maybe rebound tetanus. Thank you so much.